How did the casual, everyday vocabulary of an ancient Roman poet end up dictating life or death algorithms in modern delivery rooms?
Right. It sounds like a massive leap.
It totally is.
Yeah.
I mean, you usually encounter these words in, like, aisle 6 of the pharmacy, looking at a row of prenatal vitamins, or maybe you're sitting in a doctor's waiting room staring at an intake form on a clipboard, checking boxes about your medical history.
Yeah, and you just fill out the forms, you take the vitamins, and you probably never think twice about the vocabulary itself.
Exactly. It just fades into the background as standard medical jargon.
We all assume it's just this sterile, purely functional label. A patient sees a prefix on a chart and assumes, well, it's just the standard way doctors catalog a symptom. And this is the fascinating part, these terms aren't just static vocabulary words you memorize for a biology quiz.
Right.
They're crucial mathematical inputs. I mean, in obstetrics, these simple prefixes actually dictate clinical risk. They shape real-time hospital decisions, and they tell this profoundly detailed story about the physical toll a patient's body has endured over a lifetime.
Which is mind-blowing. And that brings us right to it. Welcome to our deep dive. Our mission today is to decode the hidden high-stakes language of obstetric charting.
It's a huge topic.
It really is. So we are zeroing in on 3 foundational roots today: gravido, nato, and paro. We've gathered medical terminology textbooks, historical records, and clinical coding standards to give you, the listener, a shortcut to understanding the vocabulary of pregnancy and birth.
Yeah, if you've ever wondered how Western medicine built its naming system, I mean, this is the journey right here.
For sure. But to understand what a modern digital chart says today in, a high-tech hospital, we have to rewind, a few thousand years?
At least. The foundation of modern obstetric charting rests entirely on the ordinary daily speech of ancient Rome.
Which is wild to think about. Okay, so these 3 roots, gravido, nato, and paro, they all orbit the same 9-month period of a pregnancy, but they track 3 entirely distinct things.
Yeah.
Let's start with gravido.
Let's do it.
This comes from the Latin adjective gravidus, or gravida, which literally translates to heavy or loaded. And I actually love this connection because it shares the exact same root as the English words gravity and grave, as in grave situation, something with serious weight to it.
That's a great way to remember it. In a clinical setting, gravido simply means pregnant or the state of pregnancy as a count. So a gravida is a pregnant woman.
Okay.
But operationally, it's used strictly as a number. Seeing gravida 3 or A3 on a chart means this patient has been pregnant 3 times.
Regardless of what happened.
Exactly.
Right.
It makes no difference how those pregnancies ended. It is exclusively a count of conceptions, nothing else.
Got it. Then we have nato. This one comes from the Latin verb nasi, or its past participle natus, meaning to be born. So this root is entirely about the event, the milestone moment of birth itself. When we say prenatal, postnatal, or neonatal, we're anchoring ourselves in time to that specific moment.
Spot on. And finally, there's paro, alongside its related combining form, pardo. This stems from the Latin verb parater, meaning to bring forth, to bear, or to give birth to.
Right.
If gravido counts the pregnancies, and nato marks the birth event, paro acts as the clinical filter. It specifically counts deliveries that reached a viable outcome.
Okay, let's unpack this.
Yeah.
You mentioned these roots come from ancient Rome, and I'm just picturing, Roman doctors sitting around in togas deliberately coining these highly technical terms for their medical scrolls just to sound professional.
Yeah, that is probably the most common misconception about medical terminology out there.
Wait, really? So they didn't do that?
Not at all. No single ancient physician invented these words for the sake of medicine. Writers like Pliny the Elder and the poet Ovid, they were using gravidus and parer in their manuscripts simply to describe everyday life.
Oh.
Yeah, a farmer might use the exact same root to describe a loaded cart or a pregnant farm animal. The survival of these specific words into modern medicine is basically just a byproduct of educational history.
How so?
Well, from roughly the 2nd century CE, so the era of the highly influential physician Galen, all the way through the 18th century, European medical schooling was conducted almost entirely in classical Latin and Greek.
Oh, I see.
So generations of doctors were just using the everyday Latin words that matched the language of their university lectures. It wasn't secret code, it was just the language of the classroom.
But then the Industrial Revolution of the 19th century completely shatters that informal tradition, right?
Yeah.
The medical field begins advancing at just a breakneck pace.
Absolutely. Anatomy and physiology become highly professionalized.
Right. And suddenly this informal system of just, speaking Latin hits a wall. It creates an absolute crisis of communication. Like, a doctor in Paris might be using a completely different Latin shorthand than a doctor in Vienna.
Yeah, they're publishing papers, they're sharing research, and suddenly realizing they literally cannot accurately communicate patient outcomes because their local jargon is entirely fragmented.
It's a mess.
A total mess. The need for standardization became desperate, so committees began forming to cure this localized chaos. The landmark moment was the Basel Nomina Anatomica of 1895.
Right, the BNA.
Exactly. It was this massive international gathering of anatomists, and their whole goal was to standardize thousands of bodily structures into one universal list. Obstetric and clinical terminology followed a similar, though maybe slightly more decentralized path through major textbook authors in the following decades.
They had to get everyone on the same page.
Right. They realized they couldn't just invent thousands of brand new words. They had to systematize the ancient ones.
I always think of this 19th century solution as a massive Lego block system.
Yeah.
Like, instead of creating new vocabulary, they invented the combining form system.
That's a perfect analogy.
They took those ancient Roman words, chopped them into modular roots, and provided this bucket of combining vowels, prefixes, and suffixes. You take the root gravid, snap on the prefix multi, and boom, multigravida.
Yep.
You snap on nulli, and you get nulligravida. It's medical Legos. It allows anyone to build a word on the fly.
And this modular system proved so resilient that it was actually crystallized for modern teaching by the mid-20th century. Programmed learning texts cemented how we teach this to nurses and allied health professionals globally.
Right.
They built a shared clinical vocabulary that translates perfectly across really every language-influenced medical tradition in the West.
And the linguistic reach extends way beyond the hospital doors, too. That nato root, nasi, to be born. You probably already use it constantly.
Oh, definitely.
It gave us the word nation, referring to a group of people born of the same origin. It gave us native and innate, meaning born within you. Even the word Renaissance literally translates to rebirth.
It's everywhere. Memorizing medical terms becomes effortless once you realize you actually already speak the root language every day.
Exactly. But having engineered these linguistic Lego blocks, the clinical world then faced its next huge challenge.
Right. Clinicians had to figure out how to translate these ancient words into a mathematical system that could accurately tell a patient's really complex reproductive story.
And we see this translation in the GTPL system. This is a 5-number code used globally in obstetric charting. GTPAL. It stands for Gravida, term births, preterm births, abortions, and living children.
And we should clarify here, in this specific medical context, abortion refers to any pregnancy lost before viability.
Right.
So that encompasses both spontaneous miscarriages and induced procedures. It's a broad clinical bucket.
Good clarification. Let's consider an example directly from our clinical sources. Say a patient's chart reads G4, T2, P1, A1, L3.
Okay, let's break that math down.
Gravida is 4, indicating 4 lifetime conceptions. Then we look at the specific outcomes of those 4 pregnancies. T2 means 2 babies were delivered at full term. P1 means 1 was delivered preterm. A1 represents 1 pregnancy lost before viability. And L3 indicates 3 living children today.
It's a lot of information in 5 digits.
It really is. This string of 5 numbers operates kind of like a sports box score.
Yeah.
Compressing years of a person's life, their joys, their medical traumas, into just a single line of data.
Yeah, it's incredibly dense. And when clinicians use the even shorter 2-number summary, just gravida and para, the math reveals a critical distinction. In your example, her gravida is 4, but her para is only 3.
Wait, why is that?
The para count drops to 3 because it only measures the deliveries that reached viability, so the 2-term and the 1 preterm. The abortion, or A1 in this case, does not count toward parity.
Okay, so this math creates 2 very distinct clinical profiles. Nulligravida versus nulliparous. A nulligravida has never been pregnant, 0 conceptions. But a nulliparous woman, she might actually have a pretty complex obstetric history. Like, if a patient has endured 2 first-trimester miscarriages, her chart reads G2P0. She's gravida 2, but nulliparous, because she's never carried a pregnancy past that viability threshold.
And clinically, separating gravida from para is absolutely vital for maternal safety. It really comes down to the physiology of the uterus.
How so?
Well, parity, rather than gravidity, correlates with measurable labor and delivery risks. When a pregnancy reaches viability, the uterine muscle stretches to an extreme degree.
Right, of course.
And during delivery, it has to contract forcefully to expel the infant and then immediately clamp down to seal off the massive blood vessels where the placenta was attached.
So we're essentially tracking the mechanical wear and tear on the organ itself.
Exactly. We are measuring physical exhaustion. Research on grand multiparity, which is conventionally defined as 5 or more prior viable births, demonstrates that this repeated stretching and contracting fundamentally alters the muscle. Yeah. A heavily taxed uterus may suffer from what we call uterine atony, where it simply lacks the muscle tone to clamp down after delivery. This seriously elevates the risk for severe postpartum hemorrhage, uterine rupture, and placental abnormalities.
That's terrifying.
It is. So if a clinician were to confuse a high Gravid count for a high perhaps, counting multiple early miscarriages as full labors, they would fundamentally miscalculate the mechanical risk to that patient's uterus.
The entire system relies on absolute precision then. But this math only functions if the entire medical community actually agrees on the rules of the game. And specifically, everyone must agree on the exact definition of a viable outcome.
Oh, boy.
Yeah, and our sources show that historically and honestly even today, they absolutely do not.
They really don't. The definition of parity hinges entirely on the viability cutoff. This is the exact moment separating an abortion, which does not count toward parity, from a parity-counted birth, which does.
And the lack of standardization here is just staggering. In the United States and Canada, the cutoff is generally placed at 20 weeks of gestation.
Right.
But you cross an international border, and the standard shifts. Some countries use 22 weeks, 24 weeks, or even 28 weeks.
Yep. And some hospital systems abandon weeks entirely. They use fetal weight cutoffs, 350 grams, 500 grams, or even 1,000 grams. Even different publications from the World Health Organization offer completely conflicting definitions depending on the specific demographic study you're reading.
Which means the real-world stakes for a patient are immense. Imagine a patient who suffers a tragic pregnancy loss at 21 weeks. If she is treated in a hospital utilizing a 20-week threshold, that event is charted as a para.
Right. It permanently increases her parity score.
But if she relocates to a hospital system with a 22-week threshold, that exact same physical event is charted as an abortion.
Yeah. The literal number on her medical chart, which dictates her hemorrhage risk protocols for every future pregnancy, changes just based on geography.
It is wild that a system designed by 19th century committees to eliminate local jargon still suffers from geopolitical fragmentation on its most foundational metric.
It creates a massive vulnerability in patient charting, without a doubt. And the complexity of parity calculations introduces another unexpected variable that frequently confuses both students and patients.
Okay, here's where it gets really interesting, because I was reading through the sources on parity rules, and I genuinely thought I found a typo.
The twin trick?
The twin trick. According to obstetric convention, twins delivered in a single labor count as one parity event, not two.
That's correct.
A woman who delivers twins is charted as para 1. I am completely lost here. She just delivered 2 distinct human beings. Why on earth does medicine count 2 babies as one event?
If we connect this to the bigger picture, we have to remember what parity is physically measuring. It tracks the physiological event of the mother. Parity is charting one cervix dilating and one uterus contracting and recovering. It's a predictive tool for the mother's future obstetric risk based on the number of labors her body has endured, completely independent of the infant head count.
Ah, I see.
One sustained labor event equals one parity point, regardless of whether it produces one infant or triplets.
Okay, think of it like one delivery truck dropping off 2 packages at a house.
I like that.
The packages are the infants, but the wear and tear on the driveway, the physical stress of the heavy truck pulling in and out, that only happened once. The medical chart is solely measuring the driveway.
That analogy captures the mechanism perfectly. Because parity is strictly focused on the mother's uterine labor, we're suddenly dealing with 2 entirely separate medical timelines the absolute second the birth ends.
Which explains the critical distinction between postpartum and postnatal. I mean, they occupy the exact same calendar window, but they track 2 entirely different patients. Postpartum utilizes the parto route, anchoring it to the mother's labor and delivery. So postpartum depression or postpartum hemorrhage refers exclusively to the mother's recovery timeline.
Right.
Whereas postnatal utilizes the nato route, anchoring it to the newborn. Postnatal jaundice or postnatal growth charts are entirely about the infant. It's the same clock, but two different bodies.
And following the chronology of a pregnancy really highlights how precise these linguistic Lego blocks can be. Long before we reach the postnatal stage, clinicians are using distinct routes to track the biological development.
Let's actually trace that biological timeline using this 19th century system. In the earliest stages, you see the root embryo tracking the cellular development. As weeks pass, the terminology shifts to feto, acknowledging the transition to a fetus.
Right.
And throughout this period, the environment is monitored using amnio, referring to the amniotic sac, which gives us procedures like amniocentesis for prenatal testing. And then, when the pregnancy reaches its conclusion, you might encounter the Greek root teutosia, meaning labor. So a difficult or obstructed labor is charted as dystocia.
Perfect breakdown. And once the delivery is complete, we enter the territory of neo, meaning new.
Neo?
Yeah. Snapping that prefix onto our birth root, neto, creates the neonate. The entire field of neonatology is surprisingly modern, actually. It only coalesced as a distinct vocabulary term in the 1960s, alongside the invention of the neonatal intensive care unit.
Wow, that is recent. And because the mother's and baby's timelines diverge at the exact moment of birth, predicting when that natal event will occur has basically always been an obsession of the medical field.
Definitely.
The standard formula used in clinics today is called Naegeli's rule. You take the first day of the last menstrual period, subtract 3 months, add 7 days, and add 1 year. It operates on a presumed 280-day gestation to mathematically pinpoint the due date.
And the rule is named after Franz Karl Nägeli, a highly influential German obstetrician working in the early 1800s. But medical historians, well, they love to point out the flaw in this naming convention.
Oh, yeah.
There's substantial evidence that Nagel did not actually invent this formula.
Right. The sources trace an almost identical version to a renowned Dutch physician, Herman Boerhaave, operating a full century earlier.
A whole century?
Yeah. Nagel simply published the rule in an incredibly popular, widely translated textbook. It proves the old adage of medical history. Eponyms, things named after people, almost always reward the popularizer who put it in print, not the quiet originator.
It's so true. The history of these terms also reveals how the medical community constantly renegotiates the balance between mathematical precision and, well, human empathy.
So what does this all mean for the patient sitting in the exam room? We have this incredibly precise, mathematically rigid system of Latin roots, but medicine is ultimately practiced by human beings, on human beings.
Exactly.
The sometimes rigid precision causes unnecessary harm. The perfect historical example from our sources is the retired term elderly primigravida.
Oh, yeah. Elderly primigravida, or the shorthand, elderly primip, was the standard medical term for decades. It was used to describe any first-time pregnant patient over the age of 35.
Over 35.
Yeah, 35. And etymologically, it is a perfectly constructed term under the combining form system. Primi meaning first, gravida meaning pregnancy.
But the American College of Obstetricians and Gynecologists, along with the broader medical community, eventually recognized that looking a 35-year-old woman in the eye and labeling her elderly was needlessly alarming.
Yeah, it carried a heavy social stigma that negatively impacted the patient's psychological well-being. So they retired a mathematically accurate term and replaced it with advanced maternal age.
It's a profound moment where the medical establishment conceded that the tone of a word matters just as much as its accuracy.
It really is. This raises an important question about the delicate balance between bedside compassion and clinical safety. We want patient-facing language to be reassuring, of course, but the clinical charting behind the scenes must remain razor-sharp. When these specific prefixes are misunderstood, the consequences are immediate and severe. Clinical case reviews consistently show that miscommunication about a patient's parity, such as a handoff where a nurse misses a gap between a high gravida count and a low para count, directly leads to delayed recognition of hemorrhage risk. The language must be exact because the physical risks to the body are exact.
Okay, let's recap the foundational roots we've unpacked today. We started with gravido, the root measuring the heavy reality of pregnancy count, tallying every single conception.
Yep.
Then we explored paro, the critical clinical filter that counts only the deliveries that push past the viability threshold, really measuring the mechanical wear and tear on the uterus.
Exact.
Finally, we looked at nato, the root marking the explosive event of birth itself, a word that echoes through our everyday language from prenatal to nation.
The entire architectural structure of parity calculation hinges on one single concept: the viability threshold. The exact gestational week of pregnancy is considered capable of resulting in a live birth, but medical technology is advancing rapidly.
super rapidly.
As artificial wombs, synthetic amniotic fluids, and revolutionary respiratory technologies develop, the medical community is finding ways to save infants at earlier and earlier gestations.
Oh,
If technology successfully pushes viability all the way back to 19 or even 18 weeks, the physiological trauma to the mother's uterus at that stage is drastically different than a full-term delivery. It forces us to ask, as science moves the goalposts of survival, will the ancient, mathematically rigid definition of parity have to be completely written for the 21st century?
that is something to think about. Thank you for joining us on this deep dive.